Good afternoon and welcome to this teleconferencing of BSc Honours in Optometry and Ophthalmic Techniques program. In this teleconferencing we will be discussing about the basic ocular sciences. I think we have been time and again we have been talking about the basic ocular sciences, and by now you must be very familiar with the topics which have been included in the basic ocular sciences. We have talked about the anatomy of the eye. You have been told about that how the eye develops when the fetus is in the during the fetal period. Embryology of the eye you have been explained. Then you have been told about the structure of the eye and various layers of the eye, and then subsequently we have been talking about the physiology of the eye. Today I will not go into that details of the individual topics, but what we will suggest that if there are any question related to this basic ocular sciences, whether it is related to the anatomy, physiology, biochemistry, or pharmacology or pathology of eye, you are most welcome to ask those questions, and we the faculty of School of Health Sciences will be able to answer these questions. So before any question comes, I think last time you were being told about the pharmacology of the eye, and it was told to you that what are the various modes of administration of drugs, and there you were told about there are systemic mode, then there are topical modes, then how the drops are being put, then how the ointments are being used. So all those things will be talking in this particular session. So what I will suggest, if there is any question, because we have not received any question from the students, if there is any particular question, you are free to ask, because this is an open session. We'll just welcome your all questions, and I have with me my two colleagues, and who will be just joining me to answer your questions. And somebody has asked me that what are the various diseases of the lacrimal gland, and if you see your books, it has been described the inflammation of the lacrimal gland is known as Dacryocystitis, and it has been classified as acute, chronic, and the congenital Dacryocystitis. And I think if you go into if you look into your books, you will find that there is signs and symptoms of acute variety, chronic variety, and the congenital varieties are mentioned there. And Mandeep, you can join us. Dr. Mandeep and Amin, you can join us. And this one of the students has asked that Dacryocystitis, what is the various infections of the lacrimal gland. So can you tell our student that what are the, as I was mentioning that there are three varieties of Dacryocystitis: acute, chronic, and congenital. Can you tell the signs and symptoms of these?
Dacryocystitis can present as a acute painful swelling at the site of the gland, and usually the patient presents with acute pain, and there is always a history of discharge from the concerned eye. And while the chronic variety, often the patient is not complaining of any pain, and they just come and say that there has been watering of the eye for past several months. But sometimes it can happen that the acute episodes can superimpose on a chronic disease. In both the cases, on examination, there would be the regurgitation test will be positive, and the type of infection can be mixed, and the treatment would be depending on whether it is an acute presentation or a chronic presentation, because usually what we do is, for an acute presentation we just let the episode subside with painkillers and antibiotics, and ultimately we will have to treat it surgically whether it is chronic or acute. It's just that we just let the acute episode subside for a few weeks, and once that has been taken care of, then we go for a surgery. But on the acute presentation, sometimes, or maybe more often than not, we may have to do an incision and drainage, for that the pus that is collected can be drained out. I think that is the...
That is about the dacryocystitis.
Yeah.
And coming down to the infection of the conjunctiva, what are the various types of conjunctivitis which one sees, and how they can be treated, how they present also?
Well, from a clinical point of view, the most common types can be infective, which is usually viral, or it can be bacterial also, and the non-infective type of conjunctivitis can be an allergic type of conjunctivitis. Sometimes it can be associated with a chemical injury. Otherwise, the presentation in most of the cases is the same: acute, painful onset of redness of the eye, which is sometimes unilateral, sometimes bilateral. But even if it is unilateral, it ultimately goes on to become bilateral after a few days. And there may be associated presentation of watering or discharge, rarely photophobia if the cornea is involved. Otherwise, the patient just says there has been a lot of discharge and painful. Associated with that, there would be swelling of the lids, or the draining lymph nodes may be swollen. And vision loss will not be there with conjunctivitis. So it can be like the photophobia or vision loss. These symptoms can be used as a distinguishing point whether the patient is presenting with a conjunctivitis or it is not. And then I think that is the...
Then, is there any this chronic conjunctivitis, and what are the complications if it is repeated infections or?
See, if it is if the patient is presenting with repeated infections of the conjunctiva, first we have to rule out a few conditions. Like we have to rule out whether there is a lacrimal gland involvement or not, because sometimes the drainage system is blocked and the regurgitation of the pus into the conjunctiva, into the inferior fornix leads to a recurrent episode of conjunctivitis. Or the patient may be diabetic, and sometimes in the Indian conditions we find that patient is coming back again and again with infections of the conjunctiva, and we find that the general hygiene is poor. Patient is applying some sort of kajal or surma to the eyes, which is usually again leading to an infection. And we have to rule out whether the patient is immunocompromised. Otherwise, there is no such thing as a chronic lingering on conjunctivitis which is happening. It is usually an acute presentation. And any other question about conjunctivitis?
So, you just mentioned that one should know that whether there is a occlusion of the lacrimal duct. So how given this?
Then again, in such a case we have to come back again to the examination of the lacrimal system. Again we go back to.
If we are examining, what are the signs which we can demonstrate that whether the duct is patent or not? How we can demonstrate that?
For the simplest thing would be a regurgitation test, when you just press on the skin over the lacrimal sac, and if the regurgitation is positive, it is clear-cut indication that it is actually a chronic dacryocystitis, which is leading on to a recurrent episodes of conjunctivitis. Or if the regurgitation is not positive, then you can go ahead with a syringing probing test, and that will just demonstrate whether there is a blockage of the lacrimal system or not. And
I mean, would you tell our students that how this tear production is done, and how because he has told about that how to test the patency of that thing. Can you tell us our students about the process of tear formation, and how the tear are secreted, and what is the
tears are basically secreted from two glands, that is main and accessory lacrimal glands. Normal tear flow is about 1.2 microliters per minute.
Yes, Rajgiri, please come up. Rajgiri, please come up. Yes, Rajgiri.
कॉर्नियल डिस्ट्रोफी कितने प्रकार का होता है, ये इसको डिफाइन करके बताएं सर, और हमारे सेंटर पे इसके बारे में कुछ नहीं बताया गया है, और एकदम समझ में हम लोग को नहीं आया है। ये दोबारा बोलेंगे? एटियोलॉजी भी बताएं सर। दोबारा बताएंगे? किसके ट्रीटमेंट सर? किसके बारे में दोबारा बोलेंगे? कॉर्नियल डिस्ट्रोफी। कॉर्नियल डिस्ट्रोफी के बारे में, कॉर्नियल डिस्ट्रोफी के बारे में बताएं सर, इसके इटियोलॉजी, उसके ट्रीटमेंट और। अच्छा, तो ये अभी हम बताते हैं आपको कॉर्नियल डिस्ट्रोफी। आई मीन यू वर टेलिंग अबाउट दैट टीयर प्रोडक्शन, you just tell that, and then we'll take up this corneal dystrophy also.
Basic secretion is from the main and accessory lacrimal glands, and reflex secretion is from the accessory lacrimal glands. Basically, the basic process is three factors are responsible: gravity, capillary action, and lead movements. There is secretion from the main lacrimal gland, then through the caniculi it passes, through the puncta it passes to the caniculi, then through the lacrimal sac to the nasolacrimal duct. Tears are drained through the passage of nose. You should know about the different layers of tear film. Outermost is the lipid layer, then we have middle one is the aqueous layer, and the inner one is the mucin layer. The lipid layer main function is it prevents evaporation of the tear film, and the middle layer, aqueous layer, it has many roles. It is the most important layer of the tear film, and its thickness is about 7 micrometers, and the inner mucin layer is responsible for the tear film stability.
What are the functions of these tears?
Basically, tears keep the normal outermost surface of the cornea moist. It forms a uniform surface of refracting surface. It fills up the irregularities of the cornea, and even it helps to flush the foreign body or toxins from the eye. Basically, for tear film evaluation is very important. There are few tests which we normally do to assess the tear film function. These are the Rose Bengal test, tear film breakup time, and shimmer test, along with the phenol red test. These are the mainly used clinical tests which we are usually doing.
Can you tell one or two tests that how they can?
Yes. Most commonly which you will use in practice is the shimmer test. Shimmer test is very easy to perform. Routinely the shimmer steps are available. They are usually 35 mm in length, and a 5 mm notch at the end is there, which you fold and insert in the lateral 2/3 of the conjunctiva. You will ask the patient, after inserting the strip, you will ask the patient to please be seated comfortably. He should not move his eyes. He should sit normally, and you will note the reading after 5 minutes. Basically, there are three types of shimmer tests: shimmer 1, Shimmer 2, basically differentiated point is, in one we use without anesthetic. We are not putting anesthetic, we are getting the total volume of tears. Total volume of tears, what we get is, that will give us whether the patient doesn't have any deficiency. But if we want to check for the basic secretion, we want to avoid the reflex secretions, then we will put the anesthetic into the eye. See, I will tell you the procedure once again. You will put the strip in the lateral 1/3 lower palpebral conjunctiva, and you will ask the patient to blink normally. After 5 minutes, you will be noting how much is the tear volume, how much in measurements will be in mm, how much the strip has become wet, and then you will record it, the measurement along with the time in 5 minutes, how much the strip has been. Normal values are above 10 mm, and 5 mm less than secretion is indicated of dry eye.
So if the eye is dry, then what has to be done?
Eye actually, in clinically we say whether the eye is moderately dry eye or severely dry eye. Usually we find most of the patients who are at the borderline. Neither, for them we can help them with artificial tears. Artificial tears then help them, and they can relieve their symptoms for the patient so that they can perform their activities comfortably. And for severe dry, then we have to go for other clinical form of treatments.
Dr. Bandeep, what you are doing in the clinical practice about these type of cases if they come?
Well, dry eyes sometimes present with very vague symptoms, and on examination very often the findings are also missing. The patient is constantly complaining of it. It can vary from severe irritation or foreign body sensation to vague complaints of pain or some heaviness of the eye or some itching. And in our day-to-day practice, we usually find most of the cases, like he says, moderate to severe dry eyes. Like on a practical point of view, you find that such patients which are coming to the clinics are most often say computer users, or due to the pollution, or they are diabetic, or the old age patients, or they may be associated mammalian gland disorders. So these things can, and there are several causes of dry eye, but if you try to rule them out one by one, it is sometimes very difficult to pinpoint the causes unless it is very obvious for certain reasons. But clinically you have to judge whether whether it is a severe case or dry, or a simple case. Then you accordingly advise the various forms of lubricating eye drops, or you can go ahead with the punctal occlusions or other forms of treatment which are available in the books.
Can it lead to corneal ulcer or sometime or something like that?
Severe cases can.
Severe cases.
Severe cases.
Not that. No.
Not because, as I said, my personal experience is sometimes you don't even pick up these subtle findings. It's just that with your experience you say that maybe this patient is suffering from a dry eye due to computer vision syndrome or something like that, and you can the moment you start them on lubricating eye drops, you find that they are okay.
You mentioned a new term, computer vision syndrome. I think that, can you explain to our learners that what is computer vision syndrome? Because they may not be, it is not mentioned in the books. Can you just mention what is this computer vision syndrome?
Well, briefly, it is seen in computer users who have been, like any visual display unit, when you are looking at it, for example, if you are watching a cricket match for a few hours, or even using computers, and then you will realize that the blink rate actually reduces, and that subsequently leads on to evaporation of the tear film and leading on to a dry eye. So what is happening here is that people who have been using computers for a long time, like we have been seeing people working in the call centers, or even people working at home, and they usually come with complaints that when I am working on the computer, suddenly the vision is blurred after some time, or I feel pain in both the eyes. I want to close my eyes and then I feel better. And something like this, the diagnosis is usually very obvious in itself by the history itself, and this is how the patient presents. Actually.
And the question was asked about corneal dystrophy, that we'll take later on. But can you tell about something about the corneal ulcers? That what are the various types of corneal ulcers before, and how they present, and what is the basic line of treatment for?
Well, corneal ulcers can be infective or non-infective. If we just, because it is a vast topic, if we just limit ourselves to infective types of ulcers, then
maybe in 10-15 minutes, if you can tell about the corneal ulcer, that I think that will help our learners to know about what in detail about the corneal ulcers.
See, the cornea infective type of ulcers would be can be viral or bacterial, and then the patient is usually presenting with a severe onset of red eye, photophobia, watering. There may be associated loss of vision, or then foreign body sensation because the surface is not intact, and you have to first we have to take the history, whether there has been a trauma to the eye, whether the symptoms have been recurring over the past few or months or so, whether it is the first time a patient has experienced this, whether it is a unit.
Yes, Delhi.
हेलो
Yes.
सर इसकी पैथोलॉजी करा दीजिए ऑर्बिट की.
ऑर्बिट की पैथोलॉजी, ओके, ठीक है, विल टेस्ट.
हाँ जी, एंड रेटिना भी सर.
रेटिना, पैथोलॉजी ऑफ ऑर्बिट एंड पैथोलॉजी ऑफ रेटिना. Okay.
Retina.
Okay, I will take that.
Okay, sir. Thank you.
We'll take up in the next session about this.
So, as I was saying that first, because if you just want to, like I would be more giving you some practical tips. If a patient is presenting with an ulcer, like how do you try to distinguish whether we have to treat it as a viral ulcer or a bacterial ulcer or a fungal ulcer? Then, as I said, the history of trauma would be one. And if it is a trauma with an organic matter, sometimes people from the farming community come and they say that some leaf or some other organic matter has fallen into the eye, or some insects have flying around, they fall into the eye, sometimes like that. So when an organic matter is involved, it is usually a fungal ulcer that you see. And when it is just a mechanical injury, it can lead on to a bacterial infection, and bacterial infection as such can itself present with the ulcer may be associated with hypopyon, or there would be say like a characteristic the characteristic lesion that can be seen on the slit lamp. The viral ulcer, again a dendritic sort of an ulcer would be seen with herpes virus, and then like it becomes very obvious that we have to go for a antiviral therapy. So once you have decided whether we are dealing with a viral ulcer or a bacterial ulcer or a fungal ulcer, then accordingly you can proceed. But basically, in addition to the anti-infective agent, the other therapy like giving the patient cycloplegics or non-steroidal anti-inflammatory agents for pain relief.
There's a call from Delhi.
Yes, Delhi, please.
Hello.
बोलिए.
Hello.
हाँ बोलिए. हाँ, गुड आफ्टरनून.
हमें एक बार एग्जाम का पैटर्न बता दोगे?
हाँ जी.
हेलो.
हाँ जी.
सर एक बार एग्जाम का पैटर्न बता दोगे?
हाँ, जरूर बता देंगे. कौन बोल रहे हैं आप?
सर क्या है?
आपका
नरेंद्र सर.
हैं?
नरेंद्र दिल्ली से सर.
नरेंद्र, ठीक है, जरूर बताएंगे आप. चलिए, फिर Dr. Mandeep, we were talking about this.
Yeah, and then we have to look out for the associated complications of corneal ulcers, and most often then not the location of the ulcer itself can be a complication itself, because a centrally located ulcer would be ultimately, even if it has healed, would be leading to a loss of vision, while a peripheral ulcer will not be affecting the vision directly in the initial stages itself. But
yes, Rajgiri.
हेलो
हाँ बोलिए.
हेलो सर, शुभम बोल रहे हैं सर. व्हाट इज हाइपोपियन सर? हाइपोपियन के बारे में जानना चाहते हैं सर, और इसका डिपोजिशन कब कब होगा, फंगल में, बैक्टीरियल में या फिर वायरल में, इसके बारे में थोड़ा बताइएगा सर.
ये तो मनदीप अभी आप हाइपोपियन के बारे में बता रहे थे.
hypopyon is basically a collection of white cells in the anterior chamber. So once you examine the eye, you will see a layer of whitish fluid. It may be mobile or it may be organized at the usually present near the 6 o'clock position, and it is seen in bacterial and fungal ulcers. And what is actually, it is a reaction sort of a thing to the infection itself. You may use it as a distinguishing feature, and you can even draw a diagram at the first visit, so that the presence or absence of hypopyon, or even if it is reducing over subsequent visits, you can use it as a sign also of whether the patient is improving or not. So hypopyon may also be seen with the severe uveitis cases or certain other diagnoses, which I will not be listing here because we will be deviating from the main topic then. But I'm just telling you this because we have to keep in mind that hypopyon is not only seen in ulcers, it can be seen in other diseases also. It's just one of the findings.
Can you just tell what are the other diseases in which hypopyon can be?
Most commonly we find in infective conditions and uveitis. Then it may be associated with tumors of the eye or other things. But commonly we just see in severe uveitis cases and ulcers.
And his question was that how we can treat it.
Hypopyon. Yes, you wanted to know how can we treat hypopyon.
No, we are not treating the hypopyon excess.
Hypopyon, I think, is a symptom.
It's the presence of white cells in the anterior chamber. So once you start the treatment, obviously it will go away. Yeah, as I said, you can even use it as a indicator whether the patient is responding to the treatment or not. Because I usually draw a diagram. The moment patient comes for the first time, I draw a diagram about how many millimeters or whether there is present, like whether hypopyon is present or not, and how much millimeters it is there. So that subsequently when I examine the patient, I know whether he is responding or not. Because if the hypopyon is increasing, that means my treatment is not taking effect, and if it is decreasing, then so it's like when you treat some other diseases, like you record the temperature or you record the BP to see whether the patient is responding. In similar case, you can use it as a help to you. You are not treating the hypopyon directly as such. You are treating the underlying cause of the disease, and hypopyon will disappear.
Hypopyon is just, you mean
it's
to
just
say
the
that is the presence of something which
white cells in the anterior chamber, and they will.
When the disease is treated, it can automatically get resolved.
It will go away. You are not treating the hypopyon directly. It is not something which is to be treated. The ulcer or the underlying disease, like as I said, ulcer has to be treated, and hypopyon will go away.
And you were talking about other types of ulcers.
As I said, like once you have decided the infective pathology, clinical examination
one thing is that anti-infective.
Yes, anti-infective, depending on, like obviously if you are not decided clinically, then you can go for corneal scrapings and go for microscopic examinations and culture, but obviously you can't wait for the culture reports, which will take some time. It may take 24 to 48 hours before you get to know what sort of organism you are dealing with. At least you will clinically you will make a judgment whether you are going ahead with the treatment. And as I said, in addition to the specific anti-infective agent, you will be using cycloplegics and non-steroidal topical agents, so that the patient is relieved. And then you can modify your treatment according to what the pathology report is presenting afterwards. And always, as I talked about hypopyon, you can you have to draw a diagram of the cornea itself. Like you have to draw whether how many millimeters the ulcer is, and the shape of the ulcer, and the presence or absence of vessels. Because all these findings, once you record, then it becomes easier in subsequent visits that you will keep recording them, and it becomes very easier to assess whether a patient is responding or not. And then I was talking about the complications. Again, there is a long list of complications which will be available in the textbooks, but usually you have to be very careful of perforations. You have to,
that is very common.
Yeah, you have to if there is an impending thing, like if there is a bulge there, you can lower the IOP with topical medication or oral acetazolamide, or then again you have to go for patching. Then you have to refer to the corneal surgeon for further treatment, because once the perforation occurs, then it becomes it is almost very difficult to save the eye, because once the patient presents to the U and the perforation already occurred, and the iris or other tissue is prolapsing out or incarcerated into the wound, then it becomes very difficult to manage it further.
Sir, is it contraindicated to give steroids for corneal ulcer?
Yes.
The reason, sir, it is commonly said we should not prescribe steroids in case of corneal ulcer. What happens if you prescribe?
See, obviously steroids should be encouraging the infective agents. So they are lowering the immunity and they are encouraging infections. So steroids are not indicated in infective ulcers. Like, we are talking about infective ulcers. Like,
yes.
so there are certain conditions, but then at this level you have to first be very sure that you are not dealing with an infective ulcer. Only then you can accordingly decide. Otherwise, if you just talk about steroids in ulcer, no, not till you are very sure that we are not dealing with an infective sort of ulcer.
Besides the anti-infective agents, what is the other line of treatment for this?
Well, it just the mode of delivery of the drug which will be different, like topical drops or ointments, or you may use systemic also if you think there's the adnexa is involved, or the source of infection is somewhere else, and otherwise it has to be case specific, what case you are dealing with.
I think there are certain questions which are of general nature. There is one fact which says that some of the universities are not being treated degrees, diplomas through distance mode of learning equivalent to the degrees, diplomas received by them. This is most unfair in view of the distance learning. What do you think about it? And I think this student is not of our program. Yes, Delhi, please come up. Yes, Delhi.
हेलो
बोलिए बोलिए।
सर, वो मुझे प्यूपिलरी डिफेक्ट्स पूछने थे, कॉर्नियल डिस्ट्रॉफी एंड स्क्विंट।
दोबारा से बोलिए।
सर, प्यूपिलरी डिफेक्ट, डिस्ट्रॉफी एंड
स्क्विंट। ओके, ठीक है, we'll take up this after the break, है ना। Now we'll just talk about this facts which has come. This is I think this does not belong to our program. The student is also 2008 batch, and we still have not enrolled any student. But let me tell you that all the degrees of IGNOUs are very much recognized by, and it is a myth that degrees, diplomas awarded by the distance learning and open universities are inferior to any other thing. So I think this conception, if you have got in your mind, that is unwanted for, and as far as IGNOU is concerned, all the degrees are recognized. lot of talk on inclusion of equity at higher education. What about economically weak? I think these questions belong to the School of Education teleconferencing. That's, I think, they must have been received afterwards. So I think these belong to that, not to us. And we are going to cover corruption in higher education system. I think these questions do not belong to our topic, so we will not take up these questions. But yes, definitely you were mentioning about the pattern of examination. The pattern of examination, I must tell you that, as you know, that there will be 4 theory papers of 70 marks. In question paper 1, that BOS 01, you will be getting that there will be English paper, and which will be of 70 marks. And the question style, pattern of questions will be same, which has been given, more or less it will be same which has been given in your assignments. It may be not, it will be not same questions, it will be not, but the pattern will be almost same. There will be little bit deviations from here and there, थोड़ा बहुत change होगा, पर by and large जो वैसा ही रहेगा. इसी तरह जो कंप्यूटर का तो आपको पता ही है, उसके लिए थ्योरी का एग्जामिनेशन होना नहीं है, उसके लिए तो प्रैक्टिकल का होगा, जो कि हम जुलाई अगस्त में बाद में करेंगे, ठीक है. और उसके बाद तीसरा जो हमारा BS 003 है, उसमें आ जाता है बेसिक ह्यूमन साइंसेज, एनाटॉमी, फिजियोलॉजी वगैरह. उसमें भी जो क्वेश्चन का पैटर्न रहेगा, वो जैसे आपने जो अगर असाइनमेंट्स करी होंगी, असाइनमेंट 3, 4, 5, 6 जो आपने करी होंगी, उसी हिसाब से अगर आप वो असाइनमेंट अच्छी तरह कर लेते हैं तो काफ़ी सारी चीज़ें आपकी समझ में आ जाती हैं. और क्वेश्चन जो है शॉर्ट नोट्स भी हो सकते हैं, डिस्क्रिप्टिव टाइप भी हो सकते हैं, फिल इन द ब्लैंक्स भी हो सकते हैं. तो इट विल बी जैसा आपका 10+2 के क्वेश्चंस आते हैं बायोलॉजी के, फिजिक्स, केमिस्ट्री के, तो दिस टाइप ऑफ क्वेश्चन यू विल बी गेटिंग. सिमिलरली देयर विल बी 4th पेपर ऑन दिस ocular, this ophthalmic optometry practices. So there will be 4 theory papers of 70 marks, and which will be containing by and large the questions of short questions, long questions, and the fill in the blanks and this type of questions. So with this Nanji.